Always so impressed by your consistency in doing these webinars. But of course, there's no shortage of things for us to talk about. And so I'm going to quickly share my screen. Um, so really, much of what I'm going to talk about is from the ethos of how and why DAG operates to begin with. And that is a recognition that the medical and public health fields have a role to play in ending genocide in Gaza and, across the world, as DAG talks about frequently. Not just through advocacy work, but also through leveraging our skill set as researchers, scholars, epidemiologists, writers, people who are trained in order to track the through many ways, track human life, track human development, to track, to see, understanding the social determinants of health, right? We recognize that health and medicine goes far beyond written outcomes, percentages, empirical data. How do people live? How are they able to eat? What is reproductive care like? And so public health is uniquely positioned to assess and measure and track those things. And yet, it is, in our view, criminally underutilized when it comes to preventing, documenting, and contributing to accountability for war crimes, including genocide. Um, Many of the pre-existing studies, especially on genocide and health, assess health post-genocide. So, 5 years after the Rwanda genocide, what are health outcomes like now? Or what are the outcomes of Holocaust survivors? Or, picking these settings of mass atrocities and assessing population health after the fact. And as this we have, so I'm speaking today, but I'm kind of speaking on behalf of my team at the Palestine Program for Health and Human Rights, which also includes Weeam Hammoudeh, Bram Wispelwey, Osama Tanous, and David Mills. We are collectively the Palestine Program for Health and Human Rights. And although we were researching Palestinian health, for many years before October 7th, 2023, we felt this was a time that called for kind of a shifting of attention, a shifting of priorities, to call attention to this. And so this piece that I'll talk through today is kind of our both a summary of some of the work that we've done that shows different components of war crimes, or what could be documentation for war crimes, as well as kind of a call to action from the public health community more broadly about our roles and responsibilities, not just as individuals, but as institutions, as organizations, as universities, as journals, as anywhere where we are, we have a role to play. So I'll just quickly talk through the four studies that are covered in the piece, and maybe we're able to put a link to the piece. It was just published last week on the New Humanitarian. So almost immediately after the beginning of the genocide, we recognized that unlike the multiple previous assaults in Gaza, and of course by 2023 there had been several, there seemed something quantitatively and qualitatively different about the civilian mortality rate at this period. And we recognized this. I mean, it didn't take long, just a few weeks in, we saw so many just, I mean, overwhelming, devastating photos and social media accounts, and, what physicians were telling us about new types of injuries they were seeing from new weaponry. And so the very first study was an attempt to look at that. And so what we found was in the first few 6 weeks that although children make up 47% of the population of the Gaza Strip, from October 7th to November 24th, 2023, they were killed at an almost equivalent proportion of 41%, which in our mind demonstrated, at the very least, indiscriminate bombing campaign that targeted and included civilians. Now, looking at the previous assaults in 2008 and 9, 2012, 2014, and 2021, we found that women and children were 30 to 41% of those killed in those attacks. And most of, those were much shorter, obviously, a few days or weeks. But from October 7th forward 6 weeks, they made up 67%. So two-thirds of those killed in the first 6 weeks of genocide were women and children. And so this was a difference, from previous assaults, and we were able to come to this very quickly. So there was all of this, if we can kind of rewind what we remember that period looking like, and all the justifications and defenses put forth by Israel and the United States about, the targeting, the most moral military in the world, as we've heard so frequently speaking, we found that through analyzing very straightforward descriptive evidence, we were able to basically puncture that argument and show that the civilian death toll demonstrated that an entirely different kind of assault was happening. Our second article focused more on the destruction of civilian infrastructure, which we defined as healthcare facilities, schools, and water collection and storage points. And again, we were just looking at the first 6 weeks in the study. So here we used kind of for us, a novel methodology of spatial analysis using satellite imagery so that we did not have to rely on people on the ground who, in many cases, were being attacked, were being displaced, were being forced to evacuate areas. We were able to utilize satellite imagery and find where there was damage to civilian infrastructure using that imagery. So we were able to characterize this damage. And again, this is just the first 6 weeks. This is not a comprehensive study, and we're working on a follow-up. So we were able to find a map of structural damage through this particular satellite data, and looking at these three types of infrastructure, we were able to find that many of them, and not just in the north where people were told to evacuate, but all throughout Gaza, which, as you all know, is a very, very small territory, these sites were either directly or indirectly attacked and damaged. And of course, damaged facilities become unusable for the population. Children were out of school almost immediately. And then we started seeing shortages in food and water relatively quickly, and as well as little access to healthcare. So in this study, if you focus just in the area around Gaza City, where some of the initial aerial bombardment was focused, we saw that more than half of health facilities were damaged directly. About almost 3/4 of education facilities and just under half of water facilities were directly damaged. And then this also indicates damage within a certain buffer zone. So as you know, it doesn't require a direct hit from a bomb to damage infrastructure. These bombs have a wide radius, and so they're able to damage even if they are within certain buffers. So we also added facilities that were damaged not directly, but by damage that was occurred 25 or 50 meters within. So critical civilian infrastructure, this is infrastructure that is meant to be protected. And obviously, we see very clearly that even in the first 6 weeks, it was subject to significant bombing. And we were also able to demonstrate that this was not random, that actually statistical analysis showed us that damage was clustered around these sites of civilian infrastructure, which suggests that there is direct targeting. Uh, so yes, damage was detected at more than half of health facilities, multiple education and water facilities, and we found that at the time, it's difficult to remember again, but there was the evacuation zone. We found significant damage in that zone, as well as on the evacuation corridor that Gazans were told to evacuate on. So if you remember at that time, they were releasing on social media videos of evacuations, of bombings during the evacuation. And so we were able to support testimonies on the ground using this satellite imagery. The third study focused specifically on damage to hospitals. And so this was directly inspired by, if you remember in the spring of 2024, there was all of this um, discussion, global discussion about the use of US supplied 2,000-pound bombs by Israel. And with many arguing that in a territory as small and densely populated as Gaza, there is no lawful use of weapons this large because inevitably they will harm civilians and civilian infrastructure. The US continued to sell these bombs to Gaza with only a temporary pause. And so we found, because these bombs are so large, The craters from these bombs were detectable using satellite imagery. And so we overlaid public data about the bomb craters made by these bombs next to the 36 hospitals throughout the Gaza Strip, again, looking at just the first month and a half or so. And we found, and we were looking specifically at the craters of these 2,000-pound M84 bombs. So we combined geospatial data with hospital locations to see how bomb craters were in relation to the hospitals. Now, we identified 592 craters from these 2,000-pound bombs, again, in just the first 5 weeks. So this is our map here. The red dots are the bomb craters, and you can see they are throughout the territory, a bit concentrated in the north, but by no means solely there. You can see in pink here was the so-called evacuation zone where there were many of these bombs detonated. And then the light blue is the hospitals in the Gaza Strip. And for those of you familiar with the Gaza health system, in the north is where Al-Shifa Hospital, which was the largest and most important hospital in Gaza, as well as many of the specialist hospitals, oncology hospitals, pediatric facilities, etc. So you can see that many of these bomb craters are extremely close to the hospitals. And because these bombs are so large, they have a very wide blast radius. So it does not require even a direct strike to cause significant damage or full destruction to these facilities. So we found that all 36 hospitals, every single one, had at least one bomb crater within 1,200 meters of the facility. The shortest distance of a bomb crater to a hospital was just 15 meters. And our findings demonstrate that 84% of hospitals were within 800 meters, and this is considered the damage and injury range of these weapons. And although the military ordered civilians, again, to evacuate to quote unquote safe zones, those zones were anything but safe and in fact also got bombed and featured significant civilian mortality as well as damage to hospital facilities, many of which providers from the north had fled to hospitals in the south so that they could provide services, so that they could consolidate resources like fuel and medical supplies. And so even in these areas, there was no safety. And we all knew that, again, from the testimonies of Palestinians on the ground. The last paper that I will talk about was we used World Health Organization data. So they were able to get daily reporting from health workers in each facility about the functionality status of the hospital. Now, for the first few weeks, obviously for the first few months, this was very difficult because providers themselves were being bombed, their families were at risk, many had fled. There were so many circumstances that made this research incredibly difficult, but they were still able to report the functionality status of their hospitals. So we looked at the first 12 months after October 7th, and we looked both at the aggregate of Gaza's complete health system as well as by governorate. And we were able to look at hospital functionality over time. So using this rapid response database by the WHO, the World Health Organization. So this was our ultimate findings. So here on the bottom are dates, starting with October 7th and then ending here at October 11th, 2024. And this indicates functionality. So green means fully functional, red is completely non-functional, and orange is partially or minimally functional. That criteria kind of changed throughout the period. And you can see that almost immediately, not a single hospital in Gaza was fully functional. And there were periods when almost no hospitals had any functionality at all. And again, this corroborates evidence from our colleagues in Gaza. So October 18th was the last date in 2023 where any hospital was fully functional, that is, able to provide kind of the full suite of services. After that point, even those that were partially functional were only able to provide kind of emergency triage care, and in some cases, that not even that. So as has covered in these webinars extensively, we were hearing reports from physicians that they were doing procedures without being able to wash their hands, with no gloves, no anesthetics, no antibiotics, almost no ability to have, medication for asthma, for type 2 diabetes, of course, for cancer care. So basically, all of those services were unavailable. By early December, more than half of 2023, more than half of all hospitals were non-functional, and that persisted throughout our entire study period. There was one point when just about 75% of the hospital system was completely non-functional. And we found, interestingly, that it wasn't just that hospitals were being bombed, although we knew that they were, but there was some hospitals were voluntarily shut down by local providers so that they could consolidate resources. If you have limited fuel, does it make sense to keep three or four or five very small hospitals minimally functional, or pool all those resources, take it to a larger facility where you can hopefully provide better care? So in some cases that has happened. In some cases, hospitals were non-functional because, again, as we saw evidence of, Israeli soldiers had besieged hospitals, had raided hospitals, had kidnapped staff. In some cases, had stayed in occupied hospitals for days or longer. And so those were also some reasons given for the non-functionality. And interestingly, some hospitals went from non-functional to partially functional multiple times, which shows the incredibly valiant efforts of healthcare workers on the ground to try to bring some level of services back, so that people did not have to travel all the way to the south or all the way to wherever the nearest hospital was. So this brings me to kind of our paper. So this was again published in the New Humanitarian just last week. And so we used these kind of four studies to frame this paper and to show some of the ways that public health can support documentation of war crimes, because there is so much discussion about the validity of claims of, Israel makes so many unfounded statements with no evidence about Hamas control and command centers, about this, that, and the other, about protection of civilians, about creating evacuation/safe zones, and very, again, just basically descriptive research, just showing what was happening on the ground, again, corroborated by local Palestinians, shows that that was inaccurate, at the very least. And so we argue in the piece that public health has, we recommend that there are some ways that public health can engage better in being able to document war crimes based on not just the studies that we conducted together, but also dozens more, if not more, studies that have been published about the genocide since October 7th, including many led by Palestinians from Gaza that are either still in Gaza or that fled to Egypt or elsewhere. So the first recommendation is just to improve the collection of public health evidence. We know that health and medicine has a particular role to play leveraging its credibility and its sense of being objective. And so our responsibility is to use that credibility to generate evidence that is protective of civilian populations suffering mass atrocities. We also found that, or we feel that public health has kind of pretty much incorporated at this point our understanding of social and structural determinants of health. And yet, in many settings of armed conflict and mass atrocity, we are only counting the dead and the injured. Now, in Gaza, because of the famine and the polio outbreak, there was some attention paid to these issues of lack of food, lack of infectious disease care. But, homelessness is a public health crisis. The bombing of so many people's homes is a public health crisis. The bombing of wells, of food factories, the killing of livestock, all of these actions that would not traditionally be considered in the scope of public health are public health responsibilities and obligations. And so our research should not just end at the epidemiological aspect of counting and determining prevalence. And yes, we do need that aspect of work, but we need to consider the whole ecosystem in which a person is living or trying to live in a setting like this to fully understand the public health impact. One thing that we found particularly useful was using adaptive methodologies to capture the full magnitude of genocide across populations and time. So we were not able to enter Gaza at this time. Very few people were. And the few journalists that were able to enter were given IDF minders. And so, aside from the Palestinian journalists on the ground, many of whom, almost more than 200, I think, at this point, have been killed, it was very difficult to get primary data from Gaza, especially in the first few months. Although many studies were published again from providers in Gaza under unimaginable circumstances. So, how can we utilize other data methods to tell the stories that we want to tell? So, in this case, using satellite imagery was one method, and using other techniques that we might not traditionally consider in our work, but are required in settings that we're unable to access or are otherwise difficult to get data out of. Importantly, and I think DAG is playing a huge role in this, recognizing genocide as a public health crisis that requires coordinated institutional action. Often I think conversations of genocide kind of center it firmly in the realm of politics, international relations, international humanitarian law. And yes, that is part of it. But, if we say as practitioners and providers of medicine and public health that it is our imperative to protect human life, to help humans thrive and survive, genocide is the number one threat to our ability to do that. And so genocide is not just a political process, but it is a mechanism of mass harm and killing. And so, is that not a threat to health? How could we not see it that way? And so, more institutional support of this kind of work rather than it remaining on the fringes. Institutional practices should align with international law and ethical obligations. So early on, we heard from many scholars, particularly Palestinian scholars, that journals were telling them they couldn't use the word genocide. They couldn't, in some cases, they couldn't use the word occupation. I talked to a graduate student doing a paper, in this case on the West Bank, and the reviewers asked her to remove the words Israel or Israeli. So instead of the Israeli military raided the refugee camp, just the military raided the refugee camp, just this kind of obscuring for no reason, and just to kind of lessen the lens on the perpetrator of these crimes. And so institutions in this case include our, the institutions in which we work, but also journals, public health and medical organizations. We saw, the American Medical Association was unable to cause for a ceasefire in Gaza. We've seen medical and public health organizations across the world kind of struggle and reckon with this, which should be confusing to those of us that are in those organizations as to why they cannot speak out and support the work of people speaking out against, uh, kind of the ultimate determinant of health, war crimes and genocide. And lastly, public health data should be incorporated into our idea of how evidence is generated into legal investigations and legal processes of genocide. So if, genocide, we should consider the percent increase of stillbirths and miscarriages in Gaza. We should consider the dip of by half of life expectancy in Gaza. These should not just be seen as issues to be considered by health providers or in health journals. They should be considered as evidence in legal proceedings. And we are seeing in the ICJ case, that South Africa has included the bombing of hospitals, the kidnapping of health workers, the lack of access to reproductive care, and other health indicators as part of their argument. So we are seeing that more so, but that should be fully incorporated. And I want to end by saying this is by no means just the work of our team. There have been many, many amazing scholars from around the world, many who are Palestinian, some still in Gaza, that have focused on a host of issues, multi-drug resistant bacteria, oral health care, malnutrition, infectious disease, counting mortality at times when the counts from the Ministry of Health were questioned. And multiple scholars that came out with mortality analysis said that it was probably actually much, much higher than what was being reported and were published in journals like The Lancet. And so then media organizations, cited some of these studies and so kind of changed the narrative because as we know, so much of this is about narrative and about whose side of the story is told, who is believed, who is listened to. And I think we have a role to play in kind of intervening in what can be in some ways very racialized processes that prioritize or give more legitimacy, in some cases, to the words of an Israeli colonel versus the words of a Palestinian doctor on the ground who is actually seeing the bodies of, seeing the ramifications of these bombs, of these raids, of these famines, of infections, of cholera, of mothers, unable to give birth in a healthy way, etc. And so we need to really reconsider all of those assumptions. And I think that this type of work is, maybe a small piece, but a really important and vital piece to keep these conversations going. So thank you so much.